Welcome to the Healthy Lifestyles Podcast, located here in Northwest Phoenix, Glendale, and Peoria. My name is Dr. Nick Hunter. I am your host, and I am a doctor of physical therapy, and I own and operate Preferred Physical Therapy, where we have helped hundreds of people aged 40 plus stay active and independent, live free from painkillers, and avoid surgery, even if they've had pain for years. This podcast is intended to help you make better decisions about your health so you can find joy in the journey by bringing together top healthcare providers, fitness experts, and nutritionists in the area to give you knowledge and confidence needed to make good health decisions. Thank you for joining us today. To help you understand how that's just not the case and how you have other options before you jump to those conclusions and settle for those options. This is perfect if you've had neck pain, if you have stiffness or difficulty moving your neck. Rotation is one that gets a lot. We get a lot of folks, I can't check my blind spot in my car, so I'm worried about safety, so that's a big thing for them. I had one gentleman say he really wants to be able to get the last gulp of juice, and he says he can't do it, and so he wants to get his neck extension to be better. So we have all kinds of different goals and reasons as to why we are looking for care or improvement. Headaches is a common thing. How are headaches relevant to our neck pain? How are they not exclusively just diet, aneurysms in the brain? I say aneurysms, but any kind of weakening or thickening of the blood vessels in our brain that can cause headaches. There's different types of headaches, and so we'll look at which ones are what we call cervicalgenic, or originating from the neck and head area. Any kind of pain down the shoulder blades. We'll talk about all this shoulder blade musculature, how sometimes we'll hear or feel like I've got a pinched nerve back there, or a lot of pain in between my shoulder blades. You can't quite get it. If you've had a lot of massages because you have pain back there and it feels like the massages can't get deep enough, how that's actually a referral pattern from your neck. And then any kind of numbness, tingling, or pain down the arms. And a lot of times these folks have been told that pills, injections, or surgery are going to be their only options. We're going to help you understand and present to you a new way. Hopefully you'll leave here knowing what are some of the common causes of neck pain. Also the best, longest lasting, and most natural treatments for neck pain, and how and why they must be done in order to give you the best chance at a full recovery without resorting to the more problematic or difficult treatment options like pills, injections, or surgery. Ultimately, we want you to be, our whole mission is to help people make better decisions about their health so they can have joy in their journey. That ultimately is why we exist, and what we want to be able to do is give you as much information and opportunity to feel like you've tried everything, done everything you can, to then make the next best healthcare decision. Ultimately, our goal is to help you live with as much joy and dignity and without regret as possible. I've had too many folks come in saying they regret having their knee replaced, regret having all the spinal fusions done, and regret not doing enough early. So many times they come in saying, I wish I would have done something sooner. Our goal is to help you feel like you have a chance now to be in a place now to where your future self will be saying, I'm really glad I did these things earlier so that I didn't have to resort to these other things in the future. It's our attempt at time travel. So many times on the phone, Julia or Christy, many of you have met Julia and Christy, they're here on the phone. I can't believe I've waited so long, or I've waited 6 months, 2 years, 10 years. We have a guy named Gilbert right now who's been 20 years with hip pain. He fell on work, never really got it taken care of. He's been in here for a month now, no longer using a cane, up walking about. He just had to adopt 3 grandbabies because of some other issues with the family. But he was so worried about how he had to only map out his ability to walk, whether at a mall or a grocery store, as to where his next seat was going to be. And he no longer wanted to live that way when he had a 13, 14, and 9-year-old kid that he just adopted at home. And so now, since working with us for the past 4 weeks, no more using a cane. He still has a limp. We're still working through a lot with his hip. But the mood and elevation of his whole spirit and being has completely changed just because he sees that there's an opportunity for him to do something when he hasn't for the last 20 years, because all the options he was being told was do this injection or you're going to have a total hip replacement, and he didn't want to do that. And so he wishes he would have done something sooner. But now again, he's thrilled that he's doing something. And who we are, Preferred Physical Therapy, ideally we help people 40 plus stay active and independent through all walks of life so that they can avoid surgeries, injections, or pain pills. This is who we are, my team. Many of which you know have met. Hannah's coming back on Monday. She just had a baby. We're excited to have her back. She was on a maternity leave. And Christy and Julia both had some time off this month because they had kids who just graduated high school. So it's been a lot of fun. Been a lot of fun having a team, having a kind of a work family together, a team that all is striving to do the same thing. A lot of lists of diseases or disorders for the neck. Any of these look familiar? Anyone been told that they have these things? We see a lot of spondylosis, degenerative disc disease. If anyone had an MRI or an X-ray for their neck? What did it say on your MRI or X-ray?
I've had, like, where your spine is in the lower bone and it sticks up like that broken.
The spinous process? You had a fractured spinous process? Okay.
I don't have a herniated disc, I have a bulging disc.
Okay. What do you understand the difference to be? Same language. So it's really the same thing. They'll have grades of herniation, which will then determine how severe the herniation is. But it's all under the same umbrella of that the disc is no longer in its original orientation, but there's been some level of injury or degeneration to the disc that's now causing some issues. And usually with disc pain or problems, severe cases will lead to nerve impingement or radiating pain down the arm, numbness and tingling, sometimes even a loss of use of that arm. Yeah. And so bulging discs, very, very common though. What we have noticed, especially over the age of 50, we start noticing just how prominent people who have bulging discs or herniated discs, very little to no symptoms. But if we x-rayed 100 of them, 40 of them would have a bulging disc and no symptoms. So just because you have a bulging disc doesn't mean that you're going to be destined to have problems. But we're going to talk a lot about herniated discs because it's very, very common. And the presentation of symptoms are often overlooked or called muscle spasms. And really the muscle spasm is secondary to the herniation. Muscle spasms are the body's attempt to help protect and heal that herniation, but often causes more problems. Anything else? Spondylosis is another big one. I think I mentioned that, but stenosis is another one. Stenosis is a narrowing of the inner central canal. It also can be a narrowing of where the nerves exit. We'll go over some anatomy in just a minute, but any else of those look familiar? What about arthritis? Anyone been told they have arthritis?
Oh, yeah.
I know. Over the age of 40, you're going to have arthritis. Even folks as early as 20, I've had people come back with neck x-rays that show early onset degeneration. Degeneration is a fancy medical term for arthritis. What can we do for arthritis? Anyone know? What can we do? I get so many folks, oh, but it's arthritis. There's nothing you can do about arthritis.
I think you should exercise.
Movement.
Yes.
The number one best thing for arthritis is movement.
I had my finger go like this, and I said, forget that, fella.
Get moving.
And I just kept wiggling it back and forth.
But so many times, Carolyn, we get told so many times, but it's arthritis. There's nothing you can do about arthritis. You can't cure it. So what do? Just give up and accept the fact that it's going to be stiff and painful forever?
That's what it bends.
Yeah.
That's the only one so far.
I get extremely frustrated when all I hear is, unlike you, people who say, but it's arthritis, nothing you can do, and they just shake it off like they're destined now to this very fast, rapidly downward spiraling problem where they're going to have this pain and dysfunction for years. And the answer is absolutely no. Get moving. Get strategic with what movements need to happen. Get strengthening. There's numerous things we can do to help combat the rate of that arthritic progression, but also the suffering that is going to happen because you do nothing about it. So absolutely, every day I try and preach and scream from the rooftops. There's tons you can do about arthritis. It's not something that you have to confine yourself as an inevitability, that there's nothing that can be done and you're just going to have to deal with it. It's not true. All right, so here's some images for the neck. The whole point of this is to help you understand the complexities of the neck, but also how it can relate to other things, other sensations that we feel, how often it's overlooked at how other things that we notice about our body can be of neck origin, but also why some skilled care is important. So x-ray on the left, I wanted to give you some context as to kind of what it looks like before we get into some of the specifics. X-rays, the number one problem with x-rays is they only show one thing, and that's bones. And so if you ever get an x-ray and they say, oh, x-ray showed I had a herniated disc, well, we can't really see that on x-ray. In fact, we can't see it at all because where do the discs exist? I'm not sure if you can see that mouse. Can you see that mouse okay? This white space here underneath here is where the discs are. And what you can't see are where the discs' edges are and where they end, where they begin and where they end. You can't see, so you can't see a herniation. What you can see is disc height. You see how there's a gap in between there? There's a healthy amount of gap, and it should be consistent throughout. Sometimes on x-ray we'll see an image report come back from the radiologist say that there's disc height narrowing. What that means is now this one looks pretty nice, how big a gap there is between these vertebral bodies. When that starts to squish down like a pancake and flatten out, we know we're going to start dealing with a couple of issues. And one is where the nerves exit. That's this space on the side that you can only see on a couple. Notice we can't see the nerves. X-rays don't pick up nerves. Where those nerves exit, as this disc squishes down like a pancake, it can compress that nerve and cause the radiating pain down. So we look at disc height. We also look at arrangement. Does that look pretty straight, or does that look curved?
Just a little bit curved, but that seems like it should be normal.
It's a little bit curved. You know what? It's too straight. It's not curved enough. And where we see that especially is that middle section.
Yes.
See that middle section? It's almost like a straight. It's angled, but it's otherwise stacked.
It's like I was looking like that before.
Right. We should have some normal curvature. We call it lordosis, or normal curvature of our neck. In our thoracic spine, we get kyphosis, which is a normal curvature rounding. Now, there's excessive degrees of each of those directions. And in the neck, when we start seeing this, we notice, okay, this person probably has a lot of muscle spasms that are clamping down on that neck, taking away that normal curvature, and causing or contributing to some neck pain. I wanted to show you the first two vertebrae. Highly specialized two vertebrae in our upper neck are these two. In fact, you can feel C1 is the very topmost. This is where the skull sits on top of the neck. There's two big, they call it the atlas for a reason, but it's because there's like scoop pieces of bone of joint surface where the skull sits on, and that gives us half of all of our neck motion is on that one spot. Extension and flexion and rotation. Half our rotation comes from C2 on C1. But these two are so important because half of all our neck movement comes from these two vertebrae. Hugely important, especially when we get stiff. A lot of bang for our buck goes into treating these two specialized vertebrae because if we can get those even half better, we know we're affecting half of our total movement. What you'll also notice is the way it's shaped. So if you guys drop down on the back of your head, go right behind your ears, you'll feel this bony spot on our skull. Okay? Drop down just a little bit more, and you'll feel another kind of bone on the outside. It's kind of jaw angle right here. Drop down just right behind it, and you'll feel kind of a bone. It's a little tender. If you push too hard, it's a little tender. There is your transverse process of C. You're a little bit too far forward. You're going to want to come back jaw angle, come right behind the jaw angle, and you'll feel those bony protuberances right there. That's C1. It's pretty big. Do you feel it, Diane?
I think so. I'm not sure.
Come right here, behind the ear, and you're going to drop down, and right in there. They're tender. They are tender. A lot of muscles will attach all along through there. So there's C1. And so what we'll do when we go in to identify just what's going on with this neck and where we're going to get our most bang for our buck in treatment is identify where that is. How is it arranged? Is it tilted or slanted? Is it stiff? How painful is it when we press on it? Again, it's normal to have some discomfort, but is it like lightning, white hot pain? Does it send pain down the arm? What happens when we add a little bit of pressure to it? And then just below this, you'll see this picture of the back of the head. Look at this bundle of muscles that we have right above my ears, right across through here. We call these the suboccipitals. Now, suboccipitals are almost as dexterous as our fingers. These are muscles that are highly specialized and unique, particularly with our very fine head movements. So if we're reading or watching something, we'll notice that we don't have to do a whole lot to keep our head in the right arrangement. There's reflexive responses from our vestibular system, which is our inner ear, and some of these muscles and our eyes that help us to stay in the right arrangement so that we don't get dizzy, lose track of our focus or focal point, and help us to stay as upright and mobile as possible. So pretty neat. I like it. Obviously, I'm a little bit nerdy about it, but what people don't understand is just headaches. How many headaches we get from these muscles right here that get pinched. Because what position do so many of us find ourselves in throughout the day? We're down here or we're here in this full extension. And we're in either one of these positions, we're putting a lot of pressure on these highly specialized micro movers and not highly specialized power or postural stabilizers. And so when we're in those positions, we really wear these out. So anytime we get headaches that kind of come up, like they feel like a ram's horn headache, sometimes they'll just sit up on the backside and just feel like here. Those are headaches that we see commonly with these, any kind of muscle spasm or tension with these muscles here. And now we go in a little deeper. Who knew they were going to get an anatomy lesson in today's presentation? Anybody have any interest in anatomy?
As long as I don't have to spell it or remember.
There won't be a quiz on this, so you'll be just fine. Here's why it's important that I want you to know about it is from a standpoint of, okay, so maybe I don't need, maybe some of my pain situation isn't something that is going to confine me to surgery or pills, but instead there's something more mechanical that can be done to help alleviate symptoms. So what I want to show you is just how many muscles are in the upper back, neck, and shoulder area. It's littered with musculature, so many. And for so many folks who have pain that come down into the shoulder blade area and down to the arm, these are ones that I want to be very, very aware of, because how do they correlate to the neck? Is you see how many actually attach from the back of the head and neck and incorporate attachments from the thoracic and cervical spine. All these become hugely important. And so a lot of folks who have shoulders that tend to roll forward, and then we get in this kind of postural position, and they feel like they get a lot of weakness or difficulty reaching overhead, or they get neck pain with reaching overhead. These are some of the issues that we have, is how do we help open our shoulders up, strengthen our postural stabilizers on the backside, all to help improve our neck function. Shoulders and neck. I usually do this presentation with both neck and shoulder pain because of how common both play a part. Today I want to just focus on the neck, but we see so many that have a high correlation of both. And so we'll look at why these muscles matter, how the attachments will correlate to different types of pain, and even what levels of the neck do some of our pain sources refer to. Now this image on the right side, all the C6s, C7s, T1s, that all relates to cervical spine nerve levels, meaning that at every level of our cervical spine we have nerves that exit and feed our arms. What's unique about our back? So sciatica, maybe some folks have had sciatica, we have pain that goes down the leg. It's from nerves that exit the spine. And so the lumbar spine has a collection of nerves that will go down and feed the limbs, and our cervical spine is also has nerves that then go down and feed our limbs. Different from our thoracic spine, because our thoracic spine will just have bands that will wrap around this way. And it's not as specialized in terms of the effect it can have on our limbs, our arms, like our lumbar spine has on our legs. And so often we'll see patients come in, I've got this pain down the arm, okay, where do you feel? Oh, it feels kind of numb or tingly. Okay, where do you feel that? And it's usually, oh, it's right down my pinky, or it's just these three fingers. It's not this one, it's just these three fingers. It's like, okay, well, it's easy to map out where the spine level is that is contributing or correlating to that kind of pain or dysfunction. And why is that important? Because if we say, okay, we're going to treat these three fingers then. Well, we can treat these three fingers all we want. It's not going to do any good because we know that the source is up at the top. And so if we're not aware of why this is important, or I get some folks who I got pain that comes down here over my elbow. And what does that sound like if they have pain over the outside of their elbow?
Like it's an elbow problem.
Could be an elbow problem. Tennis elbow. And so if we're treating this elbow pain the whole time without aware of the fact that it's actually coming up from the neck, we're not going to get any success from here and only lead to a lot of frustration. And then what do? Oh, I'm going to go in and get an injection because nothing seems to be helping. So they go in and get an injection in their elbow. No benefit. And so we want to be very aware and very good about understanding what is the root source of our pain, the root cause, so that we can prescribe the best course of treatment and action. So myofascial patterns. Anyone heard of the term myofascial patterns or myofascial pain? It's getting a lot more traction because we had no idea what fascia's purpose was, and we still really don't. But we are noticing there's something to it. We can come as far as to say we know it exists and it does something, and there's some correlation behind it not being a nerve pattern, just like this previous diagram I showed you that has these patterns of predictability. We're noticing that there is some similar correlation with myofascial patterns. So myo meaning muscle, fascia is this rigid connective band tissue. It has a little bit of stretch, but not really. If any of you have cleaned meat or chicken or anything else, and you know there's a kind of that white portion that we want to get rid of that is no good, that's fascia. And you'll notice that on some cuts of meat, there's some really thick portions of that. That's because fascia is just that, it's that separator between layers of muscle. But it also goes, it's connective from all the way down the body and all the way throughout the body. And what we're noticing is there's tracks or planes of where fascial patterns or tracks will correlate or meet. And so we're seeing referred patterns that are similar to those fascial lines or tracks. Neck and headaches is a big one. So we've noticed a lot of these muscle issues here in the front of the neck or even on the upper here of the neck. They can refer and create TMJ pain, jaw pain, more of that ram's horn headache presentation. Even back in the back of the neck and head, some of the suboccipital muscles, it's very easy to think that, oh, I've got a problem with my suboccipital muscles. Now that I've attended Nick's phenomenal course on Master Class of Neck Pain, I know all about these things. But what can happen is we have actually upper tract problems that are then referring up into the back of the head. And so if we just treat and do suboccipital strengthening exercises or mobility work, but we're still not quite getting the root source, we're going to be frustrated if, hey, that Nick guy, he doesn't know what he's talking about. Well, just wait just a minute. There's more to the story. We've got to figure out, is it a myofascial problem or is it a suboccipital problem? What's going on to better treat the root cause? I really like this diagram on the right. I use this all the time. It's this one with the yellow, red, and purple colors. This one's one of my favorites because so often I get folks who are like, oh, I got this pinched nerve in my back. And I got this pinched nerve between my shoulder blades. I can't quite get it. I massage and massage and massage. I stretch and stretch and stretch. Nothing seems to be helping it. So, okay, what have you done for your neck? Well, I don't have pain in my neck. It's all between my shoulder blades. Okay, got it. Have you ever done anything for your neck? No, I haven't. I've never had a problem there. Okay, interesting. Do a few things with his neck. Come to find out, all that pinched nerve pain goes away. Didn't massage one piece of musculature between his shoulder blades. We did all his work upper neck because C5, 6, most commonly, and this is usually where it is, it's kind of right around this border. We call them Cloward signs. I was going to put a diagram up for Cloward signs, but I figured we'll just keep it simple. C5, C6, one of the most commonly herniated discs in the cervical spine. We need to treat and gap and work and strengthen all up here to get him relief here, instead of massage after massage after massage. Maybe he gets a day of relief, but it keeps on coming back. And that's because we didn't treat the right thing. And so those myofascial pain patterns we see that go down that don't necessarily follow nerve tracks. I love this video, and I like to put it here because to really understand why tight muscles and how fascia correlate is this YouTube video where these guys have a watermelon and they put rubber bands on the watermelon. Okay, let me just play it here because it's just really fun to see. I saw this video, my boys are watching it because they watch these guys, slow-mo guys I think they're called. They just do things under slow motion capture. And I thought, oh my gosh, that's a great way to explain myofascial pain patterns. And they're like, ah, Dad, it's so boring, don't talk to me like that. Okay, I get it, but this is perfect. So rubber band after rubber band after rubber band after rubber band after rubber band until finally
get out of the way.
explodes. So going back to your son, you said, or your son-in-law? Your son, who's in these positions for long periods of time. Year after year after year, load after load after load after load is like adding rubber band after rubber band after rubber band, until finally these soft tissue cartilage surfaces, these fine little muscles that help to support, and even these discs that are supple and like a balloon between two bricks have now finally received enough load and enough strain over time consistently until now we have breakdown. Now we have an issue. And what happens is so much of those muscles have been doing their best to help support, but they haven't been able to overcome that load. And they haven't been strengthened in a way that helps them overcome that load. And then the disc will herniate. And discs, just to give you some information on how those work, they're a thick band of ligament tissue, which is a strong connective tissue that interlock kind of like this, kind of like in a fan or a weave in crisscrossing shape. Load after load after load, they can separate and weaken, and much like a balloon that has one weakened strand, when you blow it up, all the air will then push into that one pocket. It very commonly will bulge or push out into that same spot. And then what happens is we can get a full rupture, and then some of the inner, more shock-absorbing material of that disc will then push out and leak into that space of the nerve, and that's a really bad herniation, an extrusion type herniation. You'll get pain before that. You can even get numbness and tingling before that. But it's one of those where it's that same kind of thing with that watermelon with those rubber bands, and that load after load and poor position after poor position, even mismanagement of condition and not really understanding what the root cause is, will then contribute and cause that kind of injury. Not the explosion, it's not as graphic as that, but similarly in how it then breaks down and needs some care. And myofascial patterns, all our muscles have a constant level of tone or a constant level of activity. So nervous activity in our body gives our muscles the shape that they have. You'll notice people who have spinal cord injuries or stroke, what do those muscles look like? They're flat, almost look like non-existent. And it's because there's no more muscle activity or electrical activity into that muscle. The problem with myofascial patterns is that when we have a heightened level of electrical activity around those muscles because of sustained long loads, that they're not strong enough to sustain those postural positions, but we have to be kind of on high alert for those muscle patterns to work. We get increased electrical activity, more muscle spasm and tension, and then we get more pain. Who here has rubbed their arms along the upper traps and felt like concrete in their upper traps? A lot of pain. I shouldn't say a lot of pain, but you'll feel some pain, some irritation, but it feels like rock hard. And that's that higher levels of electrical activity in that area. Very, very common in our upper traps, particularly with females, particularly with moms, nurses, type A, who are just kind of high stress. You'll see them all carry a lot of that load up in their upper traps. That leads to all kinds of neck problems, a lot of myofascial tension, and rubber band after rubber band around those discs. Discs aren't the only culprit, because there are joints along those sides of the spine that can cause problems. So that's why myofascial patterns matter. All right, so we want to go over quickly. You're going to be in your seat. You're going to go over your own. If you have a partner nearby, you can ask them to take a look at you, but normal ranges of movement. In context, we want to understand some folks who are like, well, I have no problems. I got no pain. Everything seems to be fine. And then we'll go through some range of motion measurements, and we see that one is very different than the other. And when compared to what typical age-related normal levels are, they're quite different. And sometimes folks will be like, well, I don't have any pain. It doesn't really bother me, so I'm not going to do anything about it. So that's one way to go. Just like if I have a cavity in my tooth and feel like, well, it doesn't bother me, I'm just going to leave it. What's going to happen? We're going to have bigger problems later on. And it's the same kind of thing where they'll come in and say, man, I wish I would have done something sooner. And so, real quick, 90 degrees of our neck rotation, getting our chin as close to our shoulder as possible. Ideally, we're even with our shoulder. And we always check both sides. So go ahead and turn right to left. How close to your shoulder do you feel like you get? Check your partners. Sit up straight. You may have to get in your chair, because if we're quicker, we're going to change the arrangement of our neck. Sit up straight, rotate all the way over. How close do we get? Hey, not bad, John, not bad. Bonnie? Not bad, not bad. Anyone feel like they have a stiff neck? I know Diane does. We've already seen hers. She's about halfway. She's about 45 degrees.
Really?
If we look at this is straight and this is 90, 45 would be halfway.
So I should be able to look here.
You should be able to get your chin much closer. You're probably at 30 degrees here, which is quite stiff. Who else? Anyone else? Okay, the next one is flexion, chin down the neck. Ideally, we can squeeze our finger underneath our chin. Okay, how close can we get? And so sometimes we'll measure how many fingers does it take. How many fingers can I squeeze? Okay?
Do I eliminate my double chin?
Don't count your double chin. That does not count. Think bone of the chin. This is not an advantage. Bone of the chin. How close can we get? And if we feel like we can't tip at all, or we do this, we'll see this a lot, Bonnie, you're doing it a little bit too, is you'll tip over a little bit and then you go, oh, look at this though. I got really good motion. And then we rotate down. Keep your nose straight ahead. It's almost like if there were a pencil right through my nose and I'm just going to twist or turn that pencil right through my nose. Good. Not bad. Very, very stiff. We have a class leader over here.
It's like snap, crackle, and pop.
Yeah. So what you notice, it feels really tight in upper traps, stopping us from doing that. We can, if we bring our traps up and then try and go over, do I get more neck motion? If we do, great. That means we have more trap tightness, and that's something that we can work on. If we leave them down and we still have that stiffness, then we have more neck or joint problems, and we can work on that differently. But again, knowing what to work on is where it becomes very important. And then we go through shoulder movements. Just for sake of time, I want to let you have some question and answer at the end. We want to be able to go quickly through these motions. 180 degrees, arm to our ears, okay? And it's not this. We're like, oh yeah, I can get overhead. Look at how high overhead. But you see how this arm bone here is not even close to my ear. We want to get all the way there. Elbows bent tight to our side. We want to get to 90 degrees. Okay, elbows out to our side. Good. So 90 degrees is if it goes straight out from my body. If you're out here like this and it's pointing to the side, not quite 90. Okay, we want to be at 90. And then internal rotation is up our back. We want to get in between our shoulder blades. Okay, all that motion is hugely important for our shoulders. Can we scratch between our shoulder blades?
There's always a spot in my back that I can never touch it. It'll be itchy.
All right. And so at this point, I hear a lot of folks often will be like, well, don't I need an x-ray or an MRI to really know what's going on? We found out, yeah, I'm not moving so good. Okay, before we go any further, do I need to get an x-ray or an MRI so we know what's going on? And the truth of the matter is that we don't. Absolutely not. It's just like looking through the botanical gardens through the people or a knothole in a fence. You see a very small or narrow focus in any kind of image. Just like I showed you earlier, in an x-ray, we can't see any soft tissue. We can only see bone. We can make some assumptions around disc height, around disc health, but that's all they are, is some assumptions. An MRI can show a lot more. It can show nerve impingement. It can show the severity of disc herniations. But like I mentioned earlier, is if we were to scoop up 100 people over the age of 40 and give them all MRIs, 40% of them will have herniations in their discs in the neck. But not all of them are going to have neck pain. So just because we see a disc herniation and someone's complaining of neck pain, we can't just assume that that's the case. And so you only need an MRI or an x-ray if we have a suspected fracture, so a trauma, a fall, a car accident, that now your condition is different than what it was before, to confirm stability or integrity of the bones. You need an MRI only if we have suspected cancer, which could be night sweats, it could be weight loss, it could be, those are the primary ones, and then a rapid, sudden change in any kind of sensation, nerve-related going down the arm. But I mean like overnight change, where it's an immediate difference, versus one that's like, it's getting kind of worse and it's been a few months, not cancer. And then the other thing with MRI is if you're noticing weakness in your hand, and like buzzy, numbness, tingling, different than weakness, or like holding a coffee cup and it slips out of your hand, or you try and grasp something and you're losing the function of your hand or fingers, and it's been going on for a few months and you tried PT or chiropractic and nothing is changing and that's worsening, then it's time to go in and get an MRI to see what level of severity are we dealing with, and is there other things that are impinging that nerve that are causing those symptoms down the arm, because that's a bigger red flag. There's some delicacy around nerves and treating nerves, that there is some urgency around getting care of it appropriately, quickly. The longer it goes untreated, and once it gets to the point of muscle weakness, different than sensation changes, but muscle weakness, we start worrying about it being permanent change and permanent weakness, because the nerves don't regenerate that well. And yes, the air conditioning is that loud. We're down to our perfect temperature. We'll see how long it lasts. So those are some of the issues with x-rays and MRIs. There's a lot of testing that we do clinically in here with a provider that will help rule out and rule in some of these things, and then better identify what course of treatment is going to be best. The cervical spine, they've come a long way in how they treat cervical spine conditions. Surgery is one. Some common ones that we see are fusions and microdiscectomies. They are doing more disc replacements. I say more as in like a few more. They're getting better at identifying who responds better to those disc replacements. And typically it's between late 20s to early 40s and otherwise healthy will do a pretty good job of a disc replacement when they have nerve impingement from a disc that hasn't responded to anything else. And that would include pills and injections and therapy. Then they say, okay, let's do disc replacement. Otherwise, above that, they just go in and fuse it. And what does the fusion do? They just go in and cage it. They take away, they'll space the nerve, pin those two vertebrae together, and say, best of luck going forward. So they're doing a great job of coming from the front instead of going to the back, because there's far fewer issues with musculature and scar tissue. They used to go into the back, and we had all kinds of issues back then. They go in for the front. They do a phenomenal job of just cutting along a seam, kind of a wrinkle through our neck. You don't even notice a scar, but then you might be sore and hoarse through the front, and they go in and bracket it, and those do pretty good. Again, where does half of our motion come from?
Our neck.
What does half of the neck motion come from? We went over it in the first two vertebrae. The first, yeah, C1 and C2. C1 and C2. So if we fuse C5 and C6, how much reduction in motion can we expect? 10 to 20%, not a ton. We'll be okay. We'll be able to move all right, because C1 and C2 are the ones that we really want to work on. The problem with fusing any level is then it puts more strain on the joints above and below. And so it just becomes that much more important that we're attentive to keeping those mobile and strong, but also working on ones higher up so that we can still retain as much mobility as possible. A microdiscectomy is one that they'll commonly do. We see it more in the back than we do in the neck, but we still see it sometimes in the neck. They'll just go in, open up the back arthroscopically. It's just a little small hole. They'll go in and they'll shave down that herniated or bulging discs. Now, what do you think is going to happen when they shave down that thick mesh netting of support from the disc?
Weakening it.
It weakens it. Yep, it weakens it. Now it's cleaned up and offered more space, but it's weakened that disc. And what happens when that thickened supportive annular fibers around that disc, when they're gone, what happens next?
This could probably break or crack or something.
It can bulge, and then we get bigger extrusions, bigger herniations. You're exactly right. And we see that very often. Folks, oh, I had a microdiscectomy years ago. It felt amazing, and now it feels worse than ever. And it's like, okay, well, that's because we have this issue. Microdiscectomies aren't the best thing. They can be a great temporary thing, but too often we see it happens, particularly with folks in their late 20s to early 40s. It's a time of life where they heal really well, but they also are impatient. And so many will not do anything until it's now keeping them out of work. They can't do anything, can't work, focus, or function, and they want immediate results now. And those are the folks who are so willing and urgent to go into these procedures, hoping for the quick fix, not realizing that's not the best or most appropriate long-term fix. And so there's an area there where we want people to feel a bit more urgent in taking care of themselves sooner rather than later and get these things properly addressed. What are the issues with injections? Anyone had an injection? What do they say going in for the injections if you can remember?
Well, I've had lower back. And I had them in my shoulders quite a lot when I first hurt my shoulder years and years ago. And they were good for about, maybe 6 months. And then I'd go back. I had them done 3 or 4 times.
Perfect. We're talking about corticosteroid injections, or these anti-inflammatory cocktail injections that usually have about 3 drugs inside of them. One's a long-lasting pain reliever, one's a short-lasting pain reliever, but fast-acting pain reliever, and the last one's a strong anti-inflammatory, or like cortisone. That's the major one. But they usually have a cocktail of those 3 drugs in there. How many of those can you get in a year?
Oh, I tried not to ever have them that often. I had one like about every 6 months.
Yep. They try and say no more than 3 in a year in the same area. And why is that? They tell you?
About 2.
Okay. And they won't let you have more than 3 because they actually weaken and damage tissue. After 3, it's like really concerned that we're gonna cause tissue breakdown.
Is that the cortisone that causes it?
That's cortisone.
I'm allergic to that, so.
Yeah. So the issues with injection they are temporary relief, which relief can be relief, and sometimes we're okay with that as long as we're doing the right things. But there are some significant drawbacks, and one of the biggest drawbacks that I see is who likes to clean the house and sweep everything up under the rug.
My dad did that.
And does it always come back to bite you in the butt?
His wife found out.
So an injection is just like sweeping it under the rug because the underlying issue is not gone. All we've done is taken away your perception of the issue. The underlying cause is this myofascial pattern, the weakness and tightness, the breakdown of the joint. Those are the real issue. Those are what's causing pain. Just simply taking the pain away doesn't give you any of the relief at that area of the condition. It gives you just a relief of the symptom. It's just like not answering the phone when it rings. Just because you put earplugs in, the phone's still ringing, we still have problems. Same kind of thing. The issue with injections is so often it's like, oh, okay, the pain's gone, I'm good, and then we don't see them come back and get the right treatment. It's like, no, the pain's gone, that's great. Let's get in here and get it worked on so that we can get these things under control and really treat the root cause versus just allow the symptoms to go unaddressed. And so that's my biggest issue with injections is the fact that they can be highly damaging. They can break tendons, snap tissues. Arthritis is one that we've studied a lot around. We want to get some relief with arthritis. We go and inject cortisone. We have studied this over, how many years? 20 plus years now. People who have early and frequent injections in the knee are faster to have total knee replacement than one who doesn't do anything at all. And the reason why is because that cortisone breaks down cartilage and joint tissue. It does give us some temporary relief, and people are thrilled with it, and then they go on and do all the same things that they were doing that were causing the issue, but now they're doing it under the mask with the guise of no pain, when the reality is all we've done is just turn that pain signal down, and the symptoms and the condition that's causing those symptoms is still present. And so the similar things happen in the shoulder, it happens in the neck, and so one of my primary issues with injections is great as long as we do the things that are going to help the root cause, not so great if we feel like we've treated it, we cured it, when it's just not the case. And then the other thing is the fact that we have breakdown of tissue. The other thing I don't like about it is how frequent and often people are willing to just do the injections without really helping you understand that there's a better route. And when I say long-lasting natural relief, it's not from injections that are going to give you temporary relief, but then also not set you up for success in the future. Again, pain is our guide to protection. It's a warning signal. And if we shut off our warning signals, we're going to lead to bigger problems. Yeah, and there's the Mayo Clinic site that talks all about the drawbacks to injections. So this is what we do to treat is, we have this on our website. It all starts with our first phone call. We believe that care very much begins the first time that we speak on the phone. And the whole reason for that is to better understand what is going on, what you've tried, what's happened, and also what are you trying to accomplish in the end. Once we have a really good understanding of where you currently are and compare that to where you want to be, we're able to then figure out in between what needs to happen to help you get there. And within this personalized plan of care, we work on these 4 phases. where we want to work on understanding how do we get you out of this temporary and current pain, and then how do we help restore the flexibility, all that stiffness that we had, the mobility, how do we work on a strengthening program, and then once we've built up a better foundation with more flexibility and more strength, what are the activities and things that you do regularly that you need help with that now we have this new strength and motion to be able to do. And then, like anything, if we stop doing something, what happens? It comes back. Or things get worse.
You lose everything you gain.
You lose what you gain, 100%. That is one of the drawbacks of physical therapy. We will teach you and help you do a lot of things in here that you're going to feel great about, and then you're going to leave here sometimes with the understanding that I'm all better and I'm all done. And I get so many folks who will ask me when we discharge, things are great. Okay, when do I stop doing the exercises? Never. Maybe not as frequently, maybe not as intensely, maybe not like with so much concerted effort, but when do you stop exercising? Never. There's a lot of things that we want to make sure that you are fully aware of as you leave. In order to get long-term lasting relief, nothing's going to be the quick fix. Nothing's going to be a few things here and there, and then we're done. It's a matter of understanding there's a long-term game to that. So some of my favorite mobility exercises, I have worksheets, so don't feel like you got to memorize these now, but we'll have some worksheets for you to take home if you'd like to. And I printed off 8, so I'm thrilled that we have 7 of you here, so this is great. We talked about the 2 bones in our neck that are most important for our neck motion. Which one are they?
C1, C2.
C1 and C2, which is our very, very top levels of vertebrae. This first exercise, the chin tuck, seems like such a silly one. And so many times people feel like, oh, we're strengthening our deep neck flexors. And that's part of it, sure. But really what we're doing is we're working on mobilizing our C1 and C2. We're getting some extension, and then we can work on a little bit of extension through C1 and C2. And so I like chin tucks. And then I like rotation. So many times we get really stiff with rotation, very difficult to move. And so I like rotation, and I like rotation with a towel to give you some overpressure, some additional stretch. The key important feature of that is that we don't get a narrow towel and pull all across our jaw. We don't want to cause any TMJ stuff. So get up kind of high so it comes across the cheekbone and is able to scoop and hold on to as much of our skull and head as possible to give us that rotation that we're looking for. Extension. Everyone here had a hard time with extension. Extension is one that we lose quite quickly because we do spend a lot of time either at neutral or lower. I like this one, extension. The only drawbacks, if we have any issues with our arms or shoulders, this one can be a problem. And so the other one that we'll do is just hanging off the edge of a table or a bed. I say table because we call these tables, but I like bed, it's more comfortable. But you can put a few pillows and stack them up towards the edge of your bed, underneath your shoulders, and then just try and crawl off and get into more extension and hang out there. Now you notice, if you extend up, everyone look up, open and close your mouth. When you open your mouth, what do you notice happens? And keep extending. You probably notice you get a little bit further when you open your mouth than when you keep it closed. You close your mouth, you're going to feel a lot more stretch. And so we want to work on helping, okay, is it tight neck muscles that are keeping me back from extending, or is it tight joint? And if you notice, oh, I can get a lot further if I open my mouth, then we know, okay, the joint's probably okay. We got to work on these neck muscles in the front to get them to stretch a bit more. And so just knowing what we're doing and why we're doing what we're doing is helpful. And then thoracic spine. We could do another whole day course on thoracic spine. It's just not as fun and popular because it's just, there's so many other things around the thoracic spine that get the attention, like our neck and shoulders and shoulder blades, but thoracic spine is hugely important. The Journal of Orthopedic Physical Therapy, JOSPT, came out with an amazing position paper on how to most appropriately treat neck pain. And guess what was included in that paper? Treatment for the thoracic spine, because if we get really stiff, for example, we get a lot of folks who get, well, we call it kyphotic. We increase this curvature in our thoracic spine. How do you think that's going to affect, if our foundation for our cervical spine is now curved, how's that going to affect our cervical spine? Extension is hard. Overhead reach becomes really hard because I'm locked through extension or flexion in my thoracic spine. I can't get into extension. If I sit up straight, I've got a whole lot more neck and shoulder function because my foundation is in a better spot. Your thoracic spine is your foundation for neck and shoulder problems. And so we do pay attention to that. And the most problematic function of thoracic spine mobility is extension, which is why we put this one in here. This is a foam roller. You can easily do it with a towel, a beach towel, roll it up, put it in a low back chair, or you can just do it with a simple low back chair. Interlock your fingers, put it behind your neck. You can go elbows together. You can also go right here. But the reason why you want your arms in front is because we have those two flat bone shoulder blades. If I'm out this way, my shoulder blades are now pinching my thoracic spine, and I can't really extend past my shoulder blades. So get your shoulder blades out of the way, pull them forward, interlock your fingers behind your neck or cross them over your chest, and then we're going to work extension over the back of a low back chair or a towel under a high back chair that's rolled up to basically form a block to which you can mobilize your upper trunk across. My favorite strengthening exercises: off the edge of a table or chin tuck, but with resistance now, because we're going to work on strengthening all these muscles on the back side. I really like extensions for our shoulders. Carolyn's a pro at these ones. Extensions right here with some band. Elbows are straight, we're pulling down, and then the biggest key, we pull down and squeeze these shoulder blades back and down together. Hugely important that we include shoulder blade strengthening for our neck and shoulders. And then scapular retraction, same thing, just getting to know our shoulder blades, hugely important. And then another way to work rotation with some resistance. We all know, I shouldn't say we all know, but we've all maybe been to the gym or seen people exercising. Do you ever see anyone doing anything with weights for their neck? Any resistance, anything with their neck? It's all biceps and arms and legs and core and calves and all the muscles that we see and use all the time. But we often neglect any kind of strengthening for our neck. And I mean, rightly so. It's not like the most fun thing, and machines for that, they look weird. And so how do we do that? How do we strengthen the neck without...
It doesn't show.
And it doesn't, like, no one cares how it looks. You're right. We want bigger biceps. We want those tight sleeves, right? Beach body. But you're right, hugely important, because when we have stronger supportive muscles for the neck in particular, we do get less pain and tension across the joints, slower arthritis progressions, and overall maintaining function. A lot of folks have noticed if they're stiff, like it won't go any further, okay, is it joint stiffness or is it muscle weakness at end range? And so we want to work all the way through that end range. So I sometimes will have a band, just like that position with a towel. Just imagine that's now a band and we're rotating into that band to get some resistance. Same thing on both sides, okay? Here he's doing it in prone, doing it against gravity, so he's face down, elbows are up, getting some thoracic extension, which is great, and he's rotating up and away through gravity as much of his range of motion as possible in order to get some end range strengthening development. In conclusion, the neck, shoulders, and spine, quite complex, a lot of things going on, a lot of conditions and pain points can be referred to up and around that area and often overlooked, mistreated, or misinterpreted. Highly treatable. Neck pain problems, arthritis, herniated discs, radicular pain, radiating pain down the arm, all that is highly, highly treatable without injections, pills, or surgery. Always best when done earlier versus later. And one of the things that we do and that we'll continue to preach and promote is, as long as I have breath, it will be all about conservative care, early intervention makes it much easier to deal with, treat, and prolong healthy living outside of reliance on pills, injections, or surgery. If it feels like it's too late, I've let so much time go, that's also not the case. We treat people all the time who have had surgeries, who have done injections, and who are trying to get off pills all the time, because there's still so much that we can do, things that can be addressed and improved in spite of altered spinal conditions through surgery, or feeling like I've done injections and nothing seems to be helping. And that's it. Any questions?
I often wonder why I have an imbalance in my neck. You know, right through here, the right side is thicker than the left. And I don't get that.
Good question. That can be a number of different things. Sometimes we can have additional bone growth called osteophyte formation, which is just more growth around the spine. As that grows or overdevelops, it can push some of that soft tissue kind of out more so than the other side. It can be hypertrophy of muscles. One side can be more muscularly developed than the other. We see that all the time in folks who have had any lower leg injury. We'll do girth measurements for the quad. We measure it so it's the same on either side, and one quad will be quite a bit bigger than the other. And that can be from normal circumstances, no injury. It can be post-injury. We see that all the time. And so it's very easy to have one side of our neck more developed than the other side. And I know it sounds crazy, it sounds silly, but just the way that we've moved, done, worked, and progressed, one side's more than the other. We have hand dominance, right-handed versus left-handed. We see more development of musculature on the dominant side versus the other, even through things like our neck and spine. It can be a lot of things. Any other questions? Ms. Rohini?
Does the sleeping position impact the neck?
Absolutely, absolutely. And it can be, the next question that always comes is, okay, which one's the best? And that's one that's wide open. It just depends on what's going on and what you have happening. What we do know typically, because I say typically, not everyone is the same. Also, who here has woken up in the exact same position that they went to sleep in? Nobody. And the reason is we do move quite a bit at nighttime. And so we do want to start in the most comfortable position and do our best to be comfortable. But our body moves intentionally, because anytime, if you were to squeeze your finger and then take your finger off, you know how it goes from red to white and then it refills, it goes back to white? Because pressure on that side does the same thing, where it pushes blood out of that area, and our body is like, okay, we can't do that for too long unless we get tissue decay, so we have to move around. Bed sores. Anyone who's taking care of any family member knows any position, any prolonged position can cause bed sores. That's our body's natural response to preventing bed sores. How we do want to start, though, is typically on our side with our head and neck supported even to our shoulders. So we want to be even. If I'm laying on my left side, I don't want to have so many pillows where I'm pushed up in this position. I don't want to have so few where I'm hanging down. Any group of muscles or joints that are left in a closed or pinched position or a hanging open position can be left to problems. The other one is we want to have a pillow on our top arm. On left side laying, our top arm we want to have supported. When it's not supported and we allow it to hang or sag, remember these muscles that we went over, upper trap, levator scap, all these muscles that hang through here then are being pulled, and it could be like just a little bit, maybe it's like not even noticeably uncomfortable, but you feel like, oh, it's a little bit tight, like a tight band. We want to get that supported so it's short, so it's not held onto, because our body's response when it's tight is hold on. And when we hold on, we increase electrical activity to that area, we get more tightness, trigger points, and then myofascial patterns of pain. And so then we want to have a pillow between our knees for the same reason for our hips. That's usually the best place to start. And the left side usually is better. That's the side of our heart and our lungs, liver. Things are a little bit easier to work with on our left side versus our right side, usually.
Sleep on the left side?
Start on the left side.
So the head to be even with the shoulder, and you're saying for the hand that's coming on the top, have a pillow so that it's
Correct. So it feels like it can be supported and shortened.
not just hanging.
And so many times people will do that, and then when especially ladies, they get it all the time, they're going to grab all their cushions and they're going to do this, right? And then we get all kinds of issues up and down the arm and neck. We get even folks who have carpal tunnel because of the way they're sleeping. It'll either go carpal tunnel or it'll go lateral epicondylitis. And like, I don't have any problems. Then they go to reach and grab the covers and I pull them over and it's excruciating pain. That's one of the reasons. You had a question, sir?
So is that why, when I wake up, these two fingers are numb? Because I was out of line?
Possibly. Those two fingers, and we went over radicular pain, dermatomal patterns.
End of that.
And only because that's very common for ulnar nerve distribution. Ulnar nerve, also known as the funny bone, comes down through here. And a lot of folks, I'll hear that is I'll lay on my back and I'm reading and my fingers go numb right through here. They're reading. Mostly because sometimes we just have a little bit more exposed ulnar nerve through here, and because of the way that we're laying or resting our arm, it can be compressing that. What we also see, or it's a lot of tight pulled up here that can be happening to pinch, compress any portion of that nerve. It can be here, it can be in the shoulder, it can be at the elbow, it can be at the wrist. Lots of points of kink that can happen to that nerve to cause that kind of numbness.
If doctors know that these problems are causing, the prescriptions are causing us problems, why don't they refer us to physical therapy instead?
Great question. I want to know the answer to that too. Because we've got all the evidence. We know all about the opioid crisis, all about the downfall of injections, early injections, and we know the success rate for surgery isn't so great. For lumbar spine, it's like 50-50. Now for neck fusions, and here's part of the reason is, when they talk about success for surgery, they're talking about pain reduction to 50%. And that's how they're going to, for them, feel like, hey, I did a great job because I did this person 50% better. But you know what? They want to do the rest of your life. And so, you're right. I don't have a great answer for you. But I will say this. I'm not going to blame the doctors either. Because how many times does a busy doctor go in there, has 10, 15 minutes to give you the right plan, and you say, no, I don't want that. I need some help now. Give me something now. And what do they have in the next 5 minutes to give you that's going to help you now?
Pills. Drugs.
Yeah. Where I feel like there's the industry that's going to change. We've seen cab companies now get, with Lyft and Uber, completely disrupted. Okay, we've seen the technology, the way we socialize. There's a lot of things in our life that has completely disrupted because of technology. I really think healthcare is coming up. There's going to be some level of healthcare disruption where it's like, wait a minute, let's pause all this running around, all this paying insurance, all this stuff that's going on that's overburdened our healthcare providers to not be able to help patients who are actually looking for long-term natural relief. And what I'm hoping is going to happen is a lot more earlier access to care, whether that's through telehealth appointments or whatever, and then it's going to happen to say, hey, in order for you to do this, in order for you to get better, do it sooner because it's going to be easier, it's going to be more accessible, but then also go through and do this right. And it's going to be multimodal. I'm looking at developing a model where we have nutrition in-house, we have wellness in-house, and then we have physical therapy, and then we have fitness and exercise on the back end, because going forward, it's going to look like you have to be healthy from a nutrition standpoint, a vitamin standpoint, to have all the necessary construction materials in your body for the body to use in order to help it heal. And then it has to be pointed in the right direction, and then it has to be repeated over time. It has to be subscribed to and repeated over time. That's how you're going to get long-term lasting relief. Until then, we live in these pockets. And so often, doctors are limited to what they can do in that 10 to 15 minutes they have you. You may have waited 30 minutes in the weight room, 15 minutes in the back room to get their 5 to 10 minutes of attention that usually ends up in a referral to somewhere else.
But if they take the time to have a session like this for an hour to have for their patients and say, you can go this route and it's going to, give you this much of, it's going to alleviate or relieve, this one, or you can go this route, just wait on, hang on. They don't have any sessions going on, for their patients.
The world is getting more and more transparent, meaning that there's a whole lot more transparency in who is going to give you care like that, who has had success in providing care like that, and who has treated people just like you and had success. It's never been better. With the way the internet and reviews and there's so many different sites that you can go to, and a lot of people will even offer you to come in and try it out for free. There's never been a more transparent marketplace than there is now. Gone are the days of these snake oil salesmen who come in from unknown, sell a big, exciting thing, to then make a bunch of money and then get out of town having no accountability as to whether or not their snake oil was effective. It's like that's just, those reviews, that identity that is created follows you. And if you look it up and you see, hey, this people, they've got 3.5 stars, and you read some of those lower reviews and it's like, those are some of the people that sound like me who had that kind of experience, I'm not going back there. Versus here's a 5-star place that has nearly 100. We're missing 2 reviews to be 100 reviews on Google, 5 stars, that they say, hey, here's all the people that they've helped. They sound just like me. They've dealt with this kind of issue just like me for as long as I have, and they've had some success. Maybe it's not fully cured, it's not fully gone, but they're seeing better, they're moving their neck easier, sleeping better at nighttime, and now they have a better path going forward that's going to help them Maybe I'll give them a try. And going back to your insurance question, 100%. Does the amount of time, the amount of attention, and I changed that narrative to time to attention, because I can be with you for an hour, but am I attending to you for that entire hour? And that's the biggest thing. So many times, as you know, for us as a company, I moved away from the insurance model about 2.5, 3 years ago, and then fully out, just taking Medicare in 2021. Really, it was this year. It was the end of 2021 when we went out. Everything else is Medicare or cash pay. And the reason for that is because I want to be able to clear my mind and give you all my attention for the duration that you're here. Because if I don't, I'm going to miss things. And if I miss things, it's more time, more of you coming in, paying co-pays, paying deductibles, and ultimately getting less care. Versus you coming in and me spending at least 30 minutes to 60 minutes of my undivided attention on you. And when I do that, I'm able to tease out and identify what is the real reason for this versus the quick answer. If I just continue to treat the quick answer, the quick solution over time, I might get to it eventually, but how much time are you going to waste? We treated a patient named Jeannie who exhausted all 60 visits of her in-network physical therapy. She came to us with 3 back braces on. She still had 3 after 60 visits. And she's worried and stressed out about her ability to go attend her brother's wedding in Hawaii. Lugging luggage, putting in overhead bins, sitting on a 4-hour flight, and she's worried she's not going to make her brother. She's 28 years old. 3 back braces. After 2 weeks working with us, we got her down to 1 back brace. She goes on her trip, is thrilled with, she had some discomfort, she had to take some pauses away from some of the things, but she was so much better off. Came back just singing our praises and thrilled with how much progress she had made in 2 weeks, paying out of pocket. She paid directly a full 60-minute session versus the 60 visits that she exhausted somewhere else. Just,
Not everybody can afford this. That's the problem.
you're right. No, it's not fair. I completely agree with you. There's to a point where it's like, what am I willing, what sacrifices need to be made in order to be able to do that? And it's give and take. It completely is. And that's where the next industry that I feel is going to be disrupted. We're already kind of seeing it. There's a bigger squeeze on in-network insurance accepting positions where it's 3 and 4 patients an hour versus the ones like us who are going to do 60 minutes, 30-minute sessions. And there's going to be more and more of those who are going to get access to those kinds of patients to then, once they've gone through that, it's like, you know what, that's not for me. I don't want to be in those areas. What else exists? My favorite people are the ones who have been like, you know, I tried physical therapy. It doesn't work for me. Tell me about it. What kind of physical therapy did you have? And often it's the kind of, oh, I came in there, I signed in, I was on heat for a little bit. I had someone come over and tell me to do these exercises. Then they walked away. I did about 20 minutes of the same exercise before they came back and said, oh, how you doing? Are you done with that? It's like, well, was that going to be a 20-minute exercise or was that a 5-second exercise? And then they said, okay, or I was in a room for 45 minutes doing pulleys for my shoulders before anyone came in and checked on me. It's like, what's more valuable? There's going to be a bigger window of people who have been frustrated, let down by other providers because of how little time and attention they were able to get versus what we could offer here. And so, to answer your question, I think that's going to be next. Any other questions?
Why are my 2 fingers now when I am driving that I feel? I've had a steering wheel, especially this one.
And that's where we do what we call upper limb tension tests. There's 3 ways that we can test the nerves that go down the arm. There's radial, ulnar, and median. And with specific movements and patterns that we'll test, we'll know which one it is. What we can't know exactly is where along that line is it compressed. Once we do a few things, we usually can find out. But often if you're up here holding, it's usually in the shoulder. Sometimes it can be in the neck, but usually it's in the shoulder. And so we'll go through a few things to see what we can find out, why is that compressed, and then how to open it up. We see it all the time. Neck and shoulder, they dance together. Good. Any other questions? I know I'm over time, so I want to be cognizant of your time. Any other questions, feel free to ask. Otherwise, we've concluded here. I'll stick around for the next few minutes. If you have anything specific, feel free to ask. It's been a pleasure getting to talk to you guys. Anything else, let me know. We have cards up front, email address. Anyone here who for attending gets a free 30-minute consult. If you have any questions that you want to talk about specifically your case, feel free to book that up front. Preferred Physical Therapy and the guests on this show does not recommend, endorse, or make any representation about the efficacy, appropriateness, or suitability of any specific tests, products, procedures, treatments, services, opinions, healthcare providers, or other information that may be contained on or available through this content. Preferred Physical Therapy and the guests on the show are not responsible nor liable for any advice, course of treatment, diagnosis, or any other information, services, or products that you obtain through this audio recording. For specific information regarding your case, please consult a licensed professional in your area.